I am Dr. Price. I am a proud alumnus of this institution. I am so happy to be back in this room again where I spent so many hours and had so many great naps. Dr. Thompson, it was only after I had been on call. I want to thank Dr. Beverly for her organizing this symposium and for this tribute to Dr. Thompson, because like every proud alumnus of this institution, no matter where I go, if I see a Harlem alumni, they are always leaders in their community who are dedicated to excellence. And I think Dr. Thompson is the person we have to thank for that. I'm going to talk to you about heart failure. Heart failure is important. Regardless of what you have wrong with you, if the heart can pump well, it's less of a problem, especially in the various types of cardiovascular disease. If you have an arrhythmia and normal LV function, you're much better than you don't. Ventricular tachycardia. Normal LV function, you live longer if it's not failing. Ischemic heart disease, we have Killip's classification that stratifies how you're going to die after a heart attack based upon ventricular function. So here, if we had to put a face upon heart failure, it looked kind of like that. Fatigued, bloated, short of breath, increased sympathetic tone. Let's see how we can affect that. I had a patient who was a very interesting guy, and he read a lot. And whenever he would see a cartoon or a quote somewhere that he thought would be interesting to me, he would bring it. And this is one I like. This guy asked the wizard, "Do you have anything to stop the aging process?" "Yeah, we do." "What kind of disease do you want?" What we try to do in medicine is to have you age without growing old, have you die not before your time, not you die even on your time, but after your time. And how we manage heart disease has a great effect upon that. As we've heard before, if we look at how people live, white females live the longest. Black women are doing better and are paralleling white men, and black men live the least long. And if we look at populations, the Latino population lives the longest, both men and women. Now, this is a true story. I was running my slides earlier in the week. I had to get in a car to drive to the station and pick up my wife. And George Lopez, the comedian, came on the radio, the satellite communications, and he was telling a story. One of the reasons why we think the Latin population lives longer is that social support network. There is an immigrant mentality of hard work. I'm going to America to survive. And they work very hard. So George was telling a story about social networks, and he said that he had a friend who was of European descent and had gotten caught with a bag of marijuana and was arrested. And 8 people from his family went to jail to bail him out. When he got home, there was a dozen more people waiting for him and told him that we're going to support you. We're not going to let you go down to drugs. You have to be strong. And then George said, if I want to get 12 members of my family together, there had to be some reefer there. So what's taking people out? It's heart disease. We're getting better at treating heart disease, and the rates of death have been declining. Cancer is staying fairly flat. It is estimated that somewhere between 5 or 8 years, cancer may be the #1 cause of death in this country. Definition of heart failure. You know, the Supreme Architect has put a heart in your body to pump blood. When it cannot pump blood, it does not deliver the nutrients, including oxygen, to the tissues. The heart has 2 functions. It has to contract to empty, but it has to relax and fill properly. If it does either one of them improperly, you will have heart failure. Clinical manifestations: short of breath, you may be tired, you may be edematous. And we talk about heart failure and congestive heart failure. The terminology congestive heart failure is less popular because many patients don't manifest symptoms and findings of congestion as an edema, but they may have all the other symptoms that go along with it. So we are encouraging the use of the terminology heart failure as opposed to congestive heart failure. Heart failure in the U.S. Like most diseases, as you get older, it gets to be more prevalent. Above the age of 40, there's a 20% lifetime risk. There are over 500,000 new cases every year. The incidence does increase with age. As you get above 70, it increases 4 times in someone who's 85 years of age. The mortality of congestive heart failure does approach a malignant disease. Now, these numbers are getting better as we're getting better at treating heart failure, but those who have class D, or severe heart failure, have an 80% chance of dying that first year. Cost? It's very expensive. $32 billion with a B. You know, doctors get sort of a bad rep for taking all the money, but we get actually a smaller portion of that. We only get $1.8 billion, while healthcare costs, medications, lost productivity at work is the major other cause for why heart failure is such a big problem. Right? 50% of the patients who have heart failure have it with preserved ventricular function, what we formerly called diastolic dysfunction. 7% of deaths on death certificates is heart failure alone, but heart failure is prevalently prominent on many causes of death on 1 in 9 of all death certificates. Prevalence is on the increase and is estimated by the year 2030, it may be as high as 25%. That sounds like bad news, but actually not. A lot of patients who previously would have died with heart failure are now surviving because we are treating it better. 75% of the patients who have heart failure have one of the 3 things: of hypertension, ischemic heart disease, or diabetes. In the African American population, by far, the biggest cause is uncontrolled hypertension, followed by diabetes, and ischemic heart disease is third. If we look at the risk of developing heart failure, it's 4 in 1,000 person years for African Americans, followed by Hispanics, followed by whites, and then by the Chinese. Heart failure in African Americans. There's a 20 times greater risk of developing heart failure before the age of 50. As you said before, this is a disease of getting older, but not in African Americans. You will see lots of young African Americans with heart failure. And what I consider young changes with either one of the birthdays, but these people are below the age of 50. If you are Black and hospitalized for heart failure, you have a greater risk of dying in the hospital and a greater risk of having a decline in ventricular function as you leave the hospital and a decline in actual physical function when you leave the hospital. There is a decline in structural and physical function in African American patients before the onset of symptoms. What does that mean? It means that they didn't feel bad, but if you check them very carefully, like with an echocardiogram, you would find changes in their heart of a thickened heart wall, less relaxation. So the disease process has started, but they don't feel bad. And that's where we have the greatest opportunity to prevent the progression of the disease process. And how is that primarily? Aggressively treating high blood pressure. Pathophysiology, mechanical stress. You know, the heart's a muscle. High blood pressure is a resistance. If you go to the gym and lift weights, you get big biceps. If you have high blood pressure that's not well controlled, you get a thick heart muscle, mechanical stress. There's neurohormonal dysregulation, primarily that angiotensin-aldosterone axis, which puts workload on the heart. And of course, there's the ischemic injury that occurs with destructive coronary disease, and the things that happen at the cellular level, genetic mutations, abnormal calcium handling, which affect ventricular function. Heart failure in African Americans. Heart failure with preserved ejection fraction. Diastolic dysfunction. 50% of the patients who have heart failure have diastolic dysfunction. There's a question mark there in because of African Americans. Because hypertension is such a prominent etiology, there is some data that says, well, diastolic dysfunction is important, but a lot of those patients also have systolic function at the same time. Fact of the matter is, patients who have diastolic dysfunction don't have to have systolic dysfunction, But nearly every patient with systolic dysfunction, how it contracts, also have diastolic dysfunction or heart failure with preserved ejection fraction. The African American patients with higher left ventricular mass and wall thickness, a bigger, thicker, stiffer heart. They present later in the course, that is, when a patient, African American patient, comes in with heart failure, they are sicker. Many of the patients are younger, more of the patients are female, and as we said before, more of the patients have hypertension and diabetes than ischemic heart disease, although ischemic heart disease is not a small problem. And that hormonal dysregulation, reduced cardiac output stimulates baroreceptors that has something to do with other responses that occur in the renin, angiotensin, aldosterone system. There's a downregulation of beta receptors on the heart and the sympathetic nervous system. There's an increase in atronatriuretic peptides. Here are some other etiologies of heart failure: hypertension, ischemic heart disease, diabetes, valvular heart disease. Those are all important in general populations, but hypertension, diabetes, particularly in black patients, and also things like peripartum cardiomyopathies that occur. Peripartum means it occurs somewhere before delivery or somewhere soon after delivery. That is also a bigger problem in African Americans, and also in black patients in general. It's particularly high in Haiti, particularly high in Nigeria. So etiology again: hypertension, hyperglycemia, left ventricular enlargement, less coronary disease. There's greater endothelial dysfunction, that is, the lining of the blood vessels and how they dilate. They don't dilate as much in African American patients. And that can be demonstrated by doing digital and brachial vasomotor test or seeing the response to nitric oxide. African American patients have less elasticity in their arteries. Why is that? Well, there are some socioeconomic factors that come into play, and we're going to hear about that all day today. Patients who, African Americans, will delay seeking treatment. I got to go to work. I don't have insurance. I'm scared of the doctor anyway. They will be sicker on presentation when they do decide to come because they came late. There is a non-compliance with medical regimens. Part of that is a communication issue. Part of that is an understanding on behalf of why they need to do that. And I will always tell my patients, don't be more afraid of the pill than you are the problem. There may be less attentive health care providers. It's not always racism, sometimes it is, but sometimes we just take better care of people who are more like us. Sometimes it's because the doctor's busy. You got to see more patients to make less money, so you spend less time. The result: patients with heart failure have a very high readmission rate that increases that burden on the healthcare industry. Heart failure classifications, New York has a heart failure classification that's been used for years, class 1, 2, 3, and 4. There's a newer classification from American College of Cardiology and American Heart Association that looks at function and structure. So we like to stratify a patient based upon the symptoms. Symptoms can be misleading. History and physical have really not gone out of fashion or style. Dumas at the turn of the century, and not coming 2000, but from 1800s to the 1900s, said that he thought the physician's skills of physical diagnosis was going to suffer from disuse atrophy. The fact of the matter is, we are not always doing the kind of careful physical examinations that we can do, and bedside diagnosis, though, continues to be important. Chest x-rays, that's something that's easy and expensive to get. It tells us information about lung congestion and heart size. There are some laboratory testing that all our heart failure patients will need to have. But a benchmark that really is very helpful is that EKG and echocardiogram. And of course, when we're looking at the heart failure patient and trying to find out their functional capacity and whether or not they have ischemic heart disease, stress testing and cardiac catheterization. The New York Heart Association functional class, class 1, they don't have limitations. They can do whatever they want. Class 2 has mild limitations. They're asymptomatic at rest, but with some activity, do get some dyspnea or fatigue. Class 3s are symptomatic with less than regular activity, and Class 4s are symptomatic at rest. The ACC-AHA classification that depends upon structure and function, stage A, they have no structural heart disease or symptoms, but they are at risk for heart failure, which means they have some etiologic factors like hypertension, like diabetes, or have been diagnosed with ischemic heart disease. Stage Bs have structural heart disease but are asymptomatic. That's a tough group to treat. A and B are tough to treat. They don't feel bad, so why am I here? They will have, though, heart failure, heart attacks, and valvular heart disease. Class Cs have structural heart disease and have heart failure symptoms. And Class Ds have refractory heart failure requiring special intervention. The laboratory testing, everybody gets these when they come in. Most important is looking at glucose if they're diabetic, looking at the lipids, looking at excess catecholamines and some, measuring the BNP, the B-type natriuretic peptide, which can tell us if their intracardiac pressures are elevated or not. BNP is something that is very useful to get in every heart failure patient. It is sensitive but not specific, meaning that when it's up, it does tell if the patient may have heart failure, but it can also go up in someone who is older, if they have sepsis, if they have coronary disease, renal failure, and it's not specific for left ventricular dysfunction. It will also go up if they have right ventricular dysfunction as well. It will be reduced in patients who are obese, and it is reduced in pregnancy. And lastly, it is not a therapeutic guide, it is a diagnostic tool, meaning that once the patient's in the hospital, we don't follow BNP serially. We do serial examinations on the patients. It's a very expensive way to find out information that you could have gotten at the bedside. Troponins. Troponin is that enzyme that's released when a heart muscle, when a heart cell has been damaged. It doesn't tell you what that damage is. It tells you that it did occur. And it's one of those things that's been very helpful with me paying tuition, because it doesn't go by that. Rarely is there a day when I may not get a consult from one of the hospitals because somebody's troponin is elevated. And it's not often a heart attack. There are actually 5 different types of heart attacks as defined by now the American College of Cardiology. One is the traditional one, where there's obstructive coronary disease. 2 has to do with a mismatch between supply and demand, but there wasn't specific coronary artery disease, situations where there may be hyper or hypotension. Hypotension is a decrease in supply. Hypertension may be an increase in demand. Patients who have anemia, decrease in supply. Coronary spasm, decrease in supply. Arrhythmias can go either way. If it's too slow, it's decrease in supply. If it's too fast, it's increase in demand. The echocardiogram, very useful. It can tell you if a patient has normal contractility. Net ejection fraction generally is above 50%. Some places like Mayo might want to be 54%, but I think the cardiology community in general accepts 50% as the normal. So when the heart fills with blood and then contracts, it has to empty 50%. If it's less than that, you have systolic dysfunction. If it's more than that, you don't. Heart failure with preserved ejection fraction, what used to be diastolic dysfunction, the ejection fraction is greater than 50%. You will very often, especially in the African American patient, see a thickened heart wall or left ventricular hypertrophy. There will be an abnormal mitral valve flow pattern, which tells us something about what the pressures are in the heart, and that there may be this diastolic dysfunction. There'll be maybe an enlarged left atrium, as well as increase in pulmonary pressures or right ventricular systolic pressure. And this examination is useful to get for follow-up. It's inexpensive and gives you lots of information. Management of the patients. The A and B patients are really hard because they don't feel bad. But once you find that, what we have to do is manage those risk factors. You're not going to put them on medication specifically for the heart, but you will very aggressively manage their high blood pressure, get their diabetes under control, get that A1C below 7. And those are all the people who may be in that category and these problems that you have to manage. Some of the less common things that we need to talk about are like sleep apnea. There are some very specific ones to cardiology where patients who have a right ventricular pacemaker may have what's called pacing tachycardia and develop heart failure because it has an abnormally activation of the septum. In those patients, ACE inhibitors and ARBs are most useful. Thiazide-like diuretics, we say thiazide-like diuretics because hydrochlorothiazide has a reputation for being very useful for blood pressure control, but it changes your lipid metabolism, it changes your insulin resistance, which may not be good. So chlorothalidone, which is thiazide-like, doesn't do that, is becoming much more popular. The stage C patients, the patients who have preserved ejection fraction but may have some symptoms, they get diuresed carefully, right, with a loop diuretic. And you also want to control these other problems. Those who have reduced heart failure will get the ACEs, the ARBs. We add the beta blockers along with the loop diuretics. And of course, first among those are the ACEs and the ARBs, and I explained to the residents, the beta blocker does not get started in the ICU in somebody with heart failure. It gets started after they've been stabilized and are on the floor before they go home. The VHEF study early on compared the ACEs and the ARBs with a hydralazine and isosorbate dinitrate as sort of a balanced vasodilator. And we found that African American patients respond especially well to isosorbate dinitrate. And certainly we will add that on to African American patients after the other conventional therapies. And just like it was once said that ACEs and ARBs are not as effective in African Americans, which we know is not the case, it is effective if you get the right dosage. Non-African American patients who have heart failure, who have angioedema, or other reasons for not taking an ACE or ARB can take hydralazine and isosorbate dinitrate. ICDs, implantable defibrillators, in patients who have heart failure less than 35%, or if they have a heart attack and it's less than 30%, we'll get a defibrillator. You know, synchronized biventricular pacing in those patients. One of the problems with heart failure is how the heart contracts, and it loses a synchronous contractility. By putting in a biventricular pacemaker, patients can empty more efficiently. And as of last year, sacubitril valsartan, the new drug, marketed as Entresto, has been added into the guidelines for treating heart failure because it improves hospitalization, it improves cardiac output, and reduces death rates. And management of the Ds, those patients are very ill, they are symptomatic at rest, and they have an 80% chance of dying at 1 year with their heart failure. Those patients will get inotropic agents in the hospital. We don't do that with patients with a lesser class of heart failure because it can improve symptoms but reduces survival. But in these patients, their survival is so short it's not an issue. Left ventricular assist devices are now available at most major centers. We don't have enough hearts for transplantations. Left ventricular assist devices are those that are available as a bridge to transplant, but may one day become destination therapies. And in summary, in African American patients, there are different epidemiologies and outcomes. Hypertension is the predominant risk, and if we want to make a difference in heart failure, identifying the patient as heart failure early, treating them aggressively, getting the blood pressure down, using treatment strategies as per evidence-based medicine, and the socioeconomic factors that we've heard about are addressed such that it's not just in the office where we manage them, but out of the office and out of the hospital where management is important to keep them alive. Now, as my patient who gave me the cartoon would also give me quotations, and I wonder if anyone here knows the origin of the quotation, hearts will never be practical until they can be made unbreakable. That was a wizard to the Tin Man in The Wizard of Oz. I don't know how to make a heart unbreakable, but I know how to make it last a lot longer. So let's be very aggressive about identifying and treating our patients' risk.